common reason why uterine adhesions form. So basically, scar tissues should form inside of the uterus because
Mm,
when scar tissues form inside of the uterus, they limit the space where embryos can implant, affect the blood supply, and can also even have certain complications like miscarriages and
mm,
even infertility in general. So this is the reason why scar tissue shouldn't form inside of the uterus or the cervix. There are also some ways through which they can result in infertility or even cause different symptoms. I believe we'll get into that as this conversation proceeds or progresses. So basically, uterine adhesions are the cause of female factor infertility in about 5% of the cases. So when you find a woman having infertility, beg your pardon, find a woman having infertility that is caused by the uterus, that is attributed to something being wrong with the uterus. It is
mm,
because of uterine adhesions. And this condition is diagnosed in about 1.5% of women who go for HSG. Usually they come, so it's safe to say that if you have to sample a lot of women, 1.5% of them that go for HSG for one reason or the other, be it infertility or the other, they will come back with that added diagnosis of having uterine adhesions. It could be in the
mm.
form of what we will say perifembral adhesions, words like this. You just know that these adhesions are actually located in the womb itself, or maybe in a structure close to the womb, like in this case of perifembral adhesions. But we're not good. That's not our discussion for today. But we usually find people who go for HSG, about 1.5% of them being diagnosed with uterine adhesions. This condition causes recurrent miscarriages, meaning women who have miscarriage at a particular time in their the gestational age, being recurrent two, three times, four times, usually because of uterine adhesions. In about 5% of the cases of recurrent miscarriages, in 5% of women having recurrent miscarriages, it is actually attributed to uterine adhesions. And we have also seen that in 13% of women who have had first trimester termination of pregnancies, we also find uterine adhesions there. Yes, it is just like a complication of that termination of pregnancy in about 13% of women who have had voluntary, it could be voluntary termination of pregnancy. They usually end up having uterine adhesions. Okay, well, sometimes we can also still find it in people who have evacuation because of the miscarriage they had. So they just went for evacuation, and of course, it becomes like it becomes like a, well, let's use the word iatrogenic complication now of that procedure, something that maybe would result from the doctor's intervention, for that particular woman. So we've seen this also in about 20% of cases of women who go for surgery to remove fibroids inside of the womb. So usually fibroids can grow on different parts of the womb, can grow on the outer part of the womb, can grow in the muscle, or can grow even inside that space called the endometrial cavity. You could find a
Mm.
fibroid in there. So usually when people who go for surgeries, we've seen that about 20 to 26% of the people who have done removal of fibroids from inside of that space, the endometrial cavity, usually we call this kind of fibroids submucous fibroids. So women who have had removal of submucous fibroids, they are prone to having uterine adhesions in about 20 to 26% of the cases. And it even rises further to about 40% in women who have had repeated removal of fibroids from inside of the womb. Yes, some women they remove this time in a couple of years' time again. There's another one growing in there, and then they have to also remove it. So basically, these are just the figures associated with uterine adhesions. So I think I'll just stop here for now for that
Wow.
question. Yeah.
I'm just thinking in my mind, like, can we win as women? Every time we talk about things like this, I'm just like, what's going on? Like, I'm removing
Yeah.
something from my body that is causing me discomfort or pain, and then it's going to birth even something that's worse. Whew.
Yeah, I can imagine. I can
Right.
imagine your line of thoughts right now.
Yes, yes, especially like when you're in your reproductive age as a woman who's probably having children, you're about to have children. These are the things that plague, your thoughts. And then some women are just like, you know what, I cannot even bother. Them not even bother having children. But at the same time, for women who want to have children, who have this, this desire to want children, it's also very, very discouraging to hear that if I have fibroids, this is what might happen, which can ultimately hinder, me having children, fertility, and all of that. Wow. Okay. Um, I don't even know what question to ask now. You mentioned already that repeated DNCs can increase a risk of developing adhesions and all of that. But what are the early warning signs or symptoms that women should look out for that may point to uterine adhesion?
The adhesion is not so extensive. It only covers about a third, even less than a third of the uterine cavity inside of the uterus. It just covers, only takes maybe about a third of it. So usually, or less than even a third of that entire cavity. So for such women, they might not even experience any symptom at all. Okay, and then for the moderate form of it, you see that the adhesion would have extended beyond a third, down to about two-thirds of that uterine cavity. And usually at this point, the woman starts to experience all the symptoms of menstrual irregularities that I said is even the commonest, which of course is scanty menstruation, just to be specific. Scanty menstruation, menstruation that looks, usually for some women, they would be like, yeah, when I was younger, I used to have menses, it flows very well. Well, not like it is heavy, but it's normal flow. But
Yeah.
now, sometimes I just see some drops here and
Yeah.
there, and it does that for like 3 days, and then it stops, and then it repeats again the next cycle, the cycle after that, again. Usually, when you start hearing things like this, you start to suspect uterine
Mm.
adhesion. So, and like I said, from the moderate form of it, women start to experience this kind of symptoms of scanty menstruation. Usually, we call that hypomenorrhea. The next symptom that the woman can experience is cyclical pelvic pain. So what all these are grammar. What this simply means is that the woman starts to experience certain kind of pain during the time she's supposed to see her menses, or even
Okay.
after, or even before. Even can also be seen in some cases before the menses, or even after. Now I will explain. So when adhesions form, these are just like a band of tissues that form inside of the uterus. Sometimes they could create like a segment inside of the uterus. It can divide that uterus. It could get to the point where it grows from one aspect, from one wall of that cavity to touch the other cavity, dividing the uterus into both dividing that endometrial cavity into anterior and posterior segment. So what happens is that sometimes for such people, when they bleed, the menses doesn't come out. Yes, the
Mm.
menstrual bleed remains inside of the uterus. So such a woman might even be thinking that she's pregnant because she starts to experience cramping and all the pain, but she doesn't see any bleeding. And then she goes to the hospital and be like, Doctor, I've been cramping. I've not seen my menses for like 1 month, 2 months. I just want to check what is happening. I've done pregnancy tests. It is negative. When you do a scan for such a woman, you might find what we call menstruum, the blood, the bleeding, the
Hmm.
menses, the blood that's supposed to come out. You find it accumulated inside of the womb. And so the adhesion is what has prevented it from actually coming out. So usually you start to see things like this. For some women, even because of that blockage that is present inside of the womb, the menstrual bleeding or blood will not flow out through the vagina. Rather, it flows back into the
Ooh.
tubes and into the pelvic cavity. Yes, so usually we call that retrograde menstruation. Yes, because there's an outlet obstruction, so the bleeding would not even come out. So basically, we start to see things like this kind of symptoms. So, like as I've made mention of scanty menstruation. I've made mention of cyclical pelvic pain, lower abdominal pain, cramps here and there, and then there's no associated menses coming out when the time is right. And then, of course, retrograde menstruation. And then again, we can also see cases of recurrent miscarriages because of uterine adhesions. You find a woman having recurrent miscarriages upon evaluation, you find out that she has uterine adhesions. And of course, that is the reason or the basis for which experiencing the recurrent miscarriages. Then lastly is infertility, a delay in getting pregnant. So
Mm.
usually, how does uterine adhesions cause infertility? They do this through a couple of ways, but let me just take two. Number one, they can prevent sperms from getting through to the eggs. Now, remember, these adhesions are formed inside of the uterus. So the sperm has to swim from the vagina through the cervix into the womb down to the tubes where it can fertilize the eggs. And that is where it finds the egg inside of the tube. So, but when there are adhesions present, especially these moderate to severe forms of adhesions that have encompassed a larger proportion of that endometrial cavity, it will militate against the free flow or free swim up of the sperms. So it would affect sperm transport, and of course, pregnancy will be difficult to achieve in that regard. Secondly, it can also limit the space where the embryo is supposed to implant. When adhesions are formed, these are, like I said earlier, scar tissues that are formed inside of the womb. They can affect the blood supply to the inside of the womb, the endometrial cavity, where an embryo is supposed to implant. So when the blood supply is affected, the embryo might not find a conducive space for it to implant. So it can prevent pregnancy that way. And even for women who have recurrent miscarriages, because of that limitation or the limited blood supply that the uterus will be having, okay, it will not allow for the continuous growth and development of an already implanted embryo. That is for a woman that is pregnant. So this is the reason why they experience miscarriages. So I think I'll just stop here with that question.
I want to ask a question on the retrograde. Where does you said the blood doesn't come
Menstruation.
out? Menstruation, like, so where does the blood, like, is there an operation or a procedure that's done for that, for the blood to be able to come out?
Okay, yes. So that will now be the treatment for the uterine adhesions. So
Okay.
basically, there are procedures that can now be done, okay, to allow the woman to see menses the way she should and the menses flows back out. Usually, we call these procedures adhesiolysis. So that's a breaking, simply means the removal of adhesions. So when we get to the part of the treatment, we're going to speak more about that. But really, there are interventions that can be done for that woman to be able to see menses the
And
right
to
way.
that point, I know that there's quite a few women who women typically go on contraceptives, to prevent pregnancies, and for certain contraceptives, like implanon, I've heard of women who do not see their. So some women don't see their periods.
See the
Is it the
periods, yeah.
same thing? Where does the blood go? Is it the same thing?
No, 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 no. For such contraceptives, their mechanism of action is quite different from this case. Such a
Okay.
woman that is on contraceptive will not see menses because what most of these contraceptives do is that they thin out the endometrial lining. So now let me explain. Before a woman sees menses, there's a phase where they would call it the proliferative phase. So in
Mm,
this phase, the inside of the womb grows. It's just like now, let me liken it to a farmer that wants to plant. So first off, the field where he has to plant will grow with a lot of grass. Okay,
mhm.
and then he goes there to just clear everything very well. More like preparing, tilling the soil and all of that. So this is what happens. So in the proliferative phase, the endometrial tissue grows. It does that because that is the kind of it does that to allow for embryo implantation, really.
Okay.
Okay, because if it doesn't grow thick, the embryo will not find a conducive space for it to implant, and then okay, and pregnancy would result. So basically, in the early phase of your cycle, okay, just after a woman sees her menses, the endometrial tissue starts to grow.
Okay.
Okay, it grows thick. Yes. So after that, progesterone is released once the woman ovulates. So when the progesterone level starts to drop, of course, the woman will shed. The shedding will happen because progesterone is actually meant to sustain it, an embryo
Okay.
that has implanted or be removed so that menses would happen again in the next cycle. So this is what happens. So what these contraceptives do is that they make for a perpetual state of thin
Okay.
endometrium. So
Okay.
there is no growth. It's just thin. So there will be nothing to shed. So that's
To
why the
share.
woman sometimes, yeah, would not even see her menses when she's on this contraceptives. In fact, in most cases, she won't see her menses because many of these contraceptives are actually progestrogens. Progesterone would, of course, cause the thinning of an endometrium. Estrogen makes the endometrium to grow.
Okay.
Progesterone would sustain a pregnancy, sustain the development of an embryo, or cause the shedding after it has been removed. Okay, after it has been withdrawn. So, but with the presence of that progesterone in there, being that it is not an estrogen-based medication, it is not going to cause for endometrial proliferation.
Right. Okay. I just want
Yeah.
because I was like, huh? Where is the blood go? Where you said the blood was somewhere? I was like, huh, that's interesting.
Yeah.
Okay, we've talked about, how adhesions are linked to recurrent miscarriages or even failed pregnancies. We've talked about how the symptoms and the signs. We've talked about how, certain medical procedures. You mentioned HSG and even evacuation
Yeah.
can cause uterine adhesions, in the woman's body. Now, when the woman has been it has been no before even that, many women rely on ultrasounds, whether you're pregnant or for just random things that have to do with your body. Are these uterine adhesions, are they detectable during a diagnostic process, maybe during scan or during any of those things? Are they detectable? Yeah.
Okay, yes. So basically, yes, uterine adhesions can actually be diagnosed using
Okay.
very basic modalities
Okay.
like the ultrasound scan. Okay, and again, even using the HSG. Is quite a common procedure that women do to diagnose infertility, be it tubal infertility, and the rest. But they can also be
Okay.
used to diagnose uterine adhesions because they can be spotted during the HSG procedure. And of course, like I said, ultrasound scan. Even some people can even use diagnostic modalities like the hysteroscopy. So the hysteroscopy is even more superior to the in diagnosing uterine adhesions because you would have visual assessment of that. You'll be able to visualize the inside of the womb. And how is hysteroscopy done? Simply a camera, so to say, a telescope, a tube that
Mhm.
has a telescope, a camera at the end is passed into the womb. And then, of course, the doctor uses it to see the inside of the womb on a screen. Yes, just like you're watching a movie. Yeah, you'll be able to see and assess the state of even the adhesions, the extent, the severity, and all of that. And so basically, it's even more superior in diagnosing uterine adhesions.
Okay.
So basically, we said HSG, which is quite commonly done, the scans, of course, and that might also still require some level of expertise on the aspect of the
Specific.
physician. Yes, and then of course, more superior hysteroscopy can be done for the woman. Yes.
Okay. Before we get into the treatment, I want to ask
Yeah.
if um women uterine adhesions can occur without obvious symptoms. Like, can women be unaware of it until they struggle with infertility?
Oh, yes. So basically, remember I said earlier that a large proportion of women might have these adhesions and not experience any symptom at all.
Mhm.
So basically, it can be asymptomatic in some
Okay.
women where there is no symptom. The only time they find out that they have uterine adhesions is when they just go for fertility evaluation, doing all the tests, the HSGs, the scan, and then the doctor is telling you that, madam, there's some amount of adhesions at some
Mhm.
position on the uterus, and this might have been the reason why you've not been getting pregnant, blah, 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 blah. And so basically, that can be the case for some women. And well, for others, really, their own case is different. The moment they start to experience, they start to have all the transition from having normal menstrual cycle to having an abnormal one, spottings here and there, pelvic pains, and the rest. Yes, so basically, a large proportion of women will be asymptomatic. For them, it's just going to be an opportunistic finding for them, or when they go for fertility evaluation, when they start to experience delay in getting pregnant.
Okay, so let's get into treatment. What are the treatment options available? And then how do you determine the best approach for each patient?
Okay, so generally, for treatment, the gold standard of treatment for a woman having adhesions is to do what we call adhesiolysis. Adhesiolysis or adhesiolysis, as some people will call it, simply means the removal or the breakage of adhesions. And
Mhm.
there are different ways to do it. So basically, the best way to go about doing adhesiolysis is to actually do a hysteroscopic adhesiolysis.
Okay.
So this is the type of procedure where a camera again is
Like in
passed in, like a tube with a camera is passed into the uterus, and then the adhesions are then set off and all of that. So it doesn't really end there. There are interventions that have to be done post adhesiolysis that would allow for that to prevent the recurrence of adhesion formation and all of that. Okay, and generally some of these and then it simply means the passage of what we call an endometrial or a cervical balloon catheter inside of the womb. These are usually modalities that doctors are exploring these days, to just reduce the reoccurrence of adhesions.
Mm.
Because you have to know that uh, having uterine adhesions can also become a recurrent problem for certain women, in that they have uterine adhesions now, they take care of it, and then it happens again.
Mm.
Yes, because there's a high chance of reoccurrence in women, especially women who have had procedures inside of the womb and are having it maybe for a second time again. They even will stand even a higher chance of developing uterine adhesions. So women who have uterine adhesions and they go for interventions to take care of the adhesions can also put themselves at risk. It also puts them at risk of having a repeat episode,
Mm.
of the condition. Yes. So basically, the use of this uterine or cervical balloon catheter post additionalitis is a modality that is currently being explored. It doesn't end there. Of course, the use of even estrogen-based medications also help to cause endometrial proliferation after a procedure. It's also done. And of course, even the use of stem cells these days to be able to rejuvenate the endometrial cavity or endometrial tissue, for women who have had procedures, adescyolysis and the rest, is also being done to also allow for regeneration of
Mm.
that endometrium and not allow abnormal scar tissue to form inside of it. So, in this regard, part of the treatment would also still involve a kind of preventive measure for procedure. So you find women so it's just going to be like an advice really for women who would want to have voluntary termination of pregnancies, like we have said, can result termination of pregnancies can result in, especially first trimester termination of pregnancies, can result in uterine adhesions in about 13% of the cases. So we advise generally, if you must have termination of pregnancy for one reason or the other, please visit a licensed physician. Don't go about meeting just any Tom, Dick, and Harry that can do the procedure, and you've not even vetted their, professionalism and their expertise and the rest. So it is very important, yes, in that regard. Yeah.
All right. Then what happens after? Because you touched a little on the post up. What happens after? Does this mean because you already mentioned that adhesions can still occur even after
Yeah.
treatment? But what about for fertility? Like, what is the likelihood of a woman
Oh,
regaining her
yes.
fertility or even successfully? Like, there's one of regaining your fertility, but then even conceiving and then having the baby.
Okay, yes. So generally for mild case or even moderate case of uterine adhesions, usually after adesyolysis, a lot of people have recorded successes in attempts to get pregnant and even gone on there, went on to have their babies and all of that. But for the severe case of uterine adhesions, usually for some women, even post adesyolysis, they might still find it difficult even in getting pregnant. So this is where prompt evaluation for any symptom you experience as regards that is giving pointer, that is like giving a signal that is telling you, the possibility of having uterine adhesions, that's showing that there's a possibility of having uterine adhesions. It's very important to get prompt evaluation so that it can be nipped in the bud at the earliest. So you don't have to wait until it has progressed from being mild now to severe form of it, and then you're going for adesyolysis. Usually for some women, even after doing adesyolysis for a woman that has severe uterine adhesions, for some women, they might still require even surrogacy in order to help them get pregnant. Oh,
Mm.
yes, because at some point, the extent of damage might be too extensive, and it might just become a very Herculean, uh, permit me to use the word, task in order for that woman to get pregnant. So for some women, they might really need to resort to surrogacy in order to help them get pregnant. But for the mild and the moderate case, it is pretty easy that post adesyolysis and all the other interventions, medications to help to rejuvenate the endometrium and all of that, it can go on to get pregnant. Yes, even naturally, even naturally. But for some others, again, they might still have to resort to doing IVF and the rest. Yeah.
So even for the follow-up care, so after the treatment, the procedure that's been done, is there follow-up care for the women recovering from treatment?
Oh, yes. Oh yes, there's usually follow up. Yes, you can't just do so usually for the for let me just give a small scenario. So basically if a woman comes in with uterine adhesions and you've seen it, you can do your adhesiolysis, okay? And of course pass the balloon catheter in there. That woman has to come back for some people 2 weeks post that procedure for reassessment, the removal of that. That's scheduling of visit to reevaluate the woman to be sure that the job has been done well. Yeah.
Wow. Okay. Let's talk age. Does age affect women in terms of the risk of adhesions and the chances of successful treatment?
Well, age plays a role. Now, I will tell you in what respect. So, in this case, now we'll be talking about the age group of people who were engaged. Now, I just want to try to digress to just to tie something up. So, if you will find adhesions in women who are young,
Okay.
who have recurrent, like we said, recurrent termination of pregnancies, especially in this day and age where it is my body, you don't tell me how to use my body, you understand? Yeah, I'm not saying anything, I'm
I hear
just
you.
touching the surface. Yes. So they engage in all these practices, have recurrent STIs that can result in these adhesions, formations, and the rest. So basically, you do not rule out that age demography, like I mean, the younger women, reproductive within the same reproductive age. So basically, there's this propensity for them to also have these additions because of the kind of prevalence. Just we won't really find them inside of the uterus, but most likely in the cervix. So the cervix is the lower aspect of the womb in
Mhm.
layman, outlets, okay, of the uterus into the vagina. So usually for older women, especially women who are postmenopausal women are women who are stop seeing menses. Okay, yes, usually what happens is that they usually develop adhesions in the cervix. Yeah, no proper blood supply anymore. So things can just go haywire. But in that case, it won't really affect them. It won't really affect them because there is no menstruum coming out by default. They stop seeing menses. So I'm just talking about the prevalence of finding cervical adhesions now. In this case, still
Mm.
classified as uterine adhesions any which ways. In women who are post-menopausal.
Okay. Beyond infertility, because seems like infertility is really, really the elephant in the room. But are there other health risks or complications that untreated uterine adhesions can cause?
Oh yes, we made mention of the retrograde menstruation and the
Yes.
rest, and retrograde menstruation has also been seen to pose well in some regard. There are some small studies here and there about retrograde menstruation being able to result in endometriosis,
Hmm.
and of course, oh yes, and of
Yeah, but
course,
that's
that
also
can,
so tied to infertility. And is it not still?
yeah,
Yeah.
what's that? Endometriosis?
Yeah.
Yeah, oh yes, endometriosis, the uterus, you're bloated, all the symptoms that you would experience when you're supposed to see your menses, and then there's no blood.
To fertility, I'm so tired. To fertility, I'm so tired. I'm
Well,
tired.
well, it seems very unending, but the truth is, the scientific world is like they're actually not sleeping. We're actually not sleeping. There are a lot of papers by the day, even by the minute. People are posting papers of new interventions on ways to tackle old conditions because these conditions have actually been existential, So, but there
Yes.
are now newer ways to tackle them to make life even easier and all of that. So basically, it's
Okay.
a lot on the part of the woman, really, but so that's why it's still going to take a little bit of time in order to be able to get to the end of most of these conditions and just to win, to have total victory over.
All right, all right. What steps can women take to minimize their risk of developing uterine adhesions, especially, you had mentioned, or when a woman is constantly, terminating their pregnancy that they don't want, they have a risk of that. But for other women, like even for them as well, like, is there anything that they can do to minimize the risk of developing uterine adhesions, especially after miscarriages or even gynecological procedures?
Okay, well, on the aspect of the woman, basically, especially like we said, 13% of women who have recurrent, who have had first trimester termination of
Yeah.
pregnancy, especially voluntary D&Cs now. In this case, voluntary, though it's not because of the evacuation, but the
Evacuation.
one that, yes, so basically we will try to advise that, they try to be more aware about their body in order to try to prevent pregnancy even better rather than wait to get pregnant and then terminate
Okay.
pregnancy. So that is for that. Then so basically they just have to engage all the necessary practices by trying to be more sexually responsible.
Mhm.
That's the reason why I'm using that word. So
Yes.
you have to know your body, know how to have intercourse. Like by knowing how to have it doesn't mean just talk about it. We're not just talking about engaging in the act, we're talking about do it responsibly, use barrier protection and all
Mm.
the whatnot so as to prevent pregnancy if you're not ready. Then for women who are ready, there's really nothing that can be done in that regard, truthfully, because they are married. So they get pregnant, but unfortunately they have maybe a missed abortion. And so basically they have to evacuate. Yes. So it all now boils down to the aspect of the physician, on deciding the best approach in order to terminate that pregnancy. For some physicians, especially depending on the age of the pregnancy, be it early first trimester pregnancies that have become, that have become missed abortions. Maybe the baby's no longer, there's no heartbeat anymore, things like that,
Mhm.
especially in the first trimester, early first trimester specifically, early first trimester, maybe 6, 8 weeks, 8 weeks, 10 weeks. Some physicians can still decide to use medications to try to evacuate and just
Mhm.
reevaluate the woman after. However, some people do not really have time for such a slow process, so they prefer to just go in with the NVAs to do all the things. So basically, it all depends on the physician in order to, the physician has to, know what he's doing. And then when you're doing your evacuation, you know the at what extent to what point you need to stop the necessary antibiotics, medications to prevent inflammation and infection that can, cause problems in the future and all the whatnot. So it has both the things to do on the aspect of the woman and things to do on the aspect of the physician.
Yeah, yeah. I mean, I'm all for doing what you want to do, but like you rightly said, if you cannot, be abstinent, you have to make sure that you're sexually responsible. Make sure that you're
Exactly.
protecting yourself because, like I fondly tell people, whatever happens, the consequences of what your action in a sexual relationship would always stay with you as a woman, right? So you have to make sure that you know this while you go about, being sexually liberated. Okay, finally, doctor, what key message would you like to leave with women who are listening today, about protecting their reproductive health, seeking timely medical intervention? Is there any word of encouragement for women who feel like, oh, so are you saying that I'm not going to be able to have children or I have to go through surrogacy? Have you encountered, I know I'm asking multiple questions at the same time, have you encountered, women who have actually conceived? I know you mentioned earlier that some women go ahead to conceive, but have you encountered is there any story you would like to share so somebody listening can say, yeah, the doctor gave me a true life example?
Okay, so the thing with headache, truthfully, but a lot
Mm-hmm.
of people have gone on to um, let me use the word, have gone on to win against this conditions. So
Mm-hmm.
uterine adhesion, yes, is one condition that is out there, can cause infertility. A lot of people who have gone on to have interventions for them and have been successful, gone on to have babies. Even the people that prefer to do IVF because of their age, for instance, and the rest have gone on to also do their IVF and
Mm-hmm.
have gotten their babies today. So there is with met with all gynecological conditions, or generally there's nothing like never saying never. Okay, you have to say never. Like you have to just be ready now. Before I say something, you have to be ready to go the extra mile. Yes, so there's always light at the end of the tunnel. So it just depends on that courage and being motivated enough to be able to just pull through. So recently there was a woman that was having the same adhesions, and then she's desirous of having the procedure done, IVF in the hospital, but she has cervical adhesions. And then because of her age, now this is true life. Oh. She went somewhere. She went to I'm not going to make mention, which of course I find I actually their reaction of those healthcare personnel towards that woman was really, really let me use the word nasty. And honestly, on behalf of In fact, I have to apologize to the woman on behalf of the people, the so-called healthcare practitioners in the peripheral hospital she went to that I didn't know, because I felt their actions were really regrettable and should be, I don't know, I think they should desist from such practice. So they were just trying to shame the woman at your age. What are you looking for? Go and be enjoying your money and forget about babies, blah, blah, blah. I mean, who are you to, so, but what am I saying in essence is that she went on to have the procedure done regardless. And then, of course, the service was opened and she will be having an IVF procedure very soon. So it just depends on that courage. Imagine if she was deterred by their actions and all of that, by the statements they've made, abuses here and there, then she would have just aborted that journey. And at the end of the day, would not be in a position now to finish her procedure. So, with respect to uterine adhesions, basically there is a solution. Yes, there's a solution depending on, irrespective of the degree or the grading of how severe the uterine adhesion is. There is a solution. You just have to meet the right healthcare personnel, and then they will guide you. So again, remember, prompt evaluation is always key. Usually, most medical conditions are best taken care of in the early phase. Yes, if you have malaria today, usually before you, I'm just trying to digress a little bit, before you get the full-blown symptom of the malaria, the headache, the shake brain, the vomiting and everything, usually you'll be having some small non-specific symptoms for even a week or a couple of days. So if you have nipped it in the bud and started your anti-malaria medication and all the whatnot, I mean, you wouldn't even get to that point where it becomes so severe and then you're put to bed and all of that. Yeah, so this is the role of prompt, yes, evaluation.
Thank you so much, Dr. Aboloje, for today's free consultation and advice. Today was quite illuminating. I learned quite a lot, and I'm hoping that somebody that was listening also learned quite a lot as well. Dr. Collins Aboloje is an assistant medical director and fertility physician at St. Ives Specialist Hospital in Abeokuta. If you wish to get in touch with him for consultation, you can do so using the Teledoc app. You can download the Teledoc app on your phones, either Android or iOS Teledoc app. Thank you so much for coming on the show, Dr. Aboloje, once again.
Thank you for having me.
All right. Thank you for listening, and thank you for paying attention today. Radio Doctor on Women Radio 91.7 is Nigeria's first free consultation specialized radio health program, broadcast Mondays through Fridays at 10 a.m. Do join us tomorrow at 10 a.m. for another edition of Radio Doctor. Many thanks to the producer, Aisha Sani, and the executive producer, Tom Okewale Shunaya. My name is Fumi Bangbala. As always, do have a healthy day. Bye for now.